Hello, everyone, and welcome to the Mindful Running podcast. Today, we have a very special guest, Dr. Deepak Ravindran, whose book I just happened to chance upon, and I found it very, very interesting. And I thought, he should definitely be invited to the next podcast on this platform. So I'm very happy to get Deepak here today. Dr. Deepak Ravindran is an upstreamist with a trauma informed approach to pain practice. He has over 20 years of experience in pain management and is the clinical lead in pain medicine at the Royal Berkshire Hospital in Reading, Berkshire, UK. He is one of the very few consultants in the UK who holds triple certification in musculoskeletal, pain medicine, and lifestyle medicine. Dr. Deepak Ravindran is a speaker and a podcast host of the channel Pain Speak and author of the Amazon bestseller, The Pain Free Mindset. This book is aimed at patients suffering with pain, but also immensely useful for all healthcare professionals in understanding all the recent advances around pain management in a trauma informed manner. So, with that, I would get Deepak live. Hi, Deepak.
Hi, Soumya, and thank you for having me on your podcast channel.
Yeah, most welcome, and very excited to have you here, and very excited to talk to our audience about your book. And the name itself is very interesting because I think this is applicable to just about anyone and everyone who is human, because pain is something that everyone lives with in some form or the other. So I think it's going to be a very interesting conversation, Deepak. And yeah, we'll jump right in.
Yeah, likewise, Soumya. I think thank you. I think talking to a lot of our Indian audiences, I've been doing a few now, so this is a very nice opportunity to reach out to another group, and the fact that you have been doing this mindful running podcast and the kind of audience that you'll be having there, it'll be interesting because I think a lot of what I've written in the book will be quite applicable, as you said, to anyone, but there will be definitely, hopefully, a rationale for those people watching your podcast and listening to you as well.
Yeah, absolutely. And while I have personally read the book, I would, really want people to take a look at this book because it. I mean, we'll talk about it, so I don't want to like talk about it immediately and straight away. So just to start with, Deepak, what is, for the audience, what is your book, The Pain-Free Mindset, all about? And this is your first book, I guess, right? That you've written, and what made you really talk about this subject and write this?
So, great starting point there, Soumya. And so, my book is called The Pain Free Mindset, and the mindset itself is almost a double meaning word. On one bigger level, it is about asking everyone to really change our mindset about how we look at pain. What we thought of pain needs to have a reframe. So, that is on one level, relook at what pain actually means to us, what the research and the science is now telling us on how we should view and interpret pain. As you said, whatever kinds of pain we have. The second thing, at a more practical level, the mindset itself is an acronym. So each of the 7 letters of mindset is an acronym for what I think should be a toolkit in everyone wanting to overcome any kind of pain that they may be having. And our most often in mainstream medicine or within healthcare, when we get pain, our instinctive worry is there something going on? And we want to look at some medications, or we want to look at an interventions, whether that is surgery, yeah, it is some injection or some major sort of intervention like physiotherapy, vagera. So we have that but after that, we don't think beyond that, ki aur kuch kya karna hai? What else do I do beyond the M and the I? And that's where the N, the neuroscience of what happens in your nervous system when you perceive pain. Then the D stands for what kind of diet and microbiome, the way we understand our ecosystem in the intestine and how we can influence it. The S stands for sleep. The E stands for physical activity and exercise. And T finally stands for a lot of mind body therapies, in which our Indian audiences and our Indian population, our parents, my mom, my grandma, they all have such a wealth of experience, and it was always considered as spiritual or Eastern ways. But now the Western side is understanding the robust scientific research that shows how these mind body therapies can also make a difference. So, my book is essentially a plea to set the record straight in light of the new evidence, and actually tell the public at large, anyone, whether they have pain, whether you are a carer of someone who lives with pain, or whether you're someone just interested in knowing what the science of pain and how far it has advanced. This is a book that aims to inform Joe Public and the person who is walking on the street there, to say that there is a lot of hope when you create a toolkit, a kind of pain free mindset to overcome the pain, rather than just being stuck in sometimes that helpless cycle of what is the next drug and what is the next surgery or injection. That's the whole premise
Right.
of the book.
Right. And it's very interesting because the way the word mindset is broken down and is very easy to remember also, very creatively done. And there are times, like you said, that the first thing that comes into our mind is if you're not feeling well or if you're in pain, medication. Like you have to pop a pill to feel better. That's such a normal and a common thing with all of us. So you've actually kind of brought about the whole package to us, that sure, there are medicines and there are interventions when needed. You're not saying this completely eliminate them. There is a time for those, but there are so many other factors. If you take care of those, maybe you don't need the M and the I.
Precisely. I think the evidence, and you're right, this is almost baked into our culture, and this is not just our Indian culture and the way we grew up, but it is also in the Western side, where I've now lived in the UK for almost 17 years now. um, it's the same principle and the same cultural beliefs that there must be a medication. And in this day and age, in this zamana of swipe right and swipe left and you get an answer, you think that there should be a quick fix for everything. And what the evidence is unfortunately showing, ki even if you take the best medicine, if you, whatever you may think about drugs like morphine or very strong stuff, even if you take the best drug for pain management, they work only 30% of the time in 30% of the people. एंड जब वो काम करते हैं तो maximum efficacy is 30 to 50%. That is the evidence. Of course, nobody is saying that some people might be there who have complete pain relief with one or two tablets of something that they take, and that may be fine for them. Broadly, कुछ लोग हो सकते हैं कि they may have correct response to a drug. That's fantastic. But when the evidence, you look at it in a population level, it isn't very great. And the same with surgeries as well. Any kind of orthopedic surgery that you take, the evidence base for it is that it doesn't work in everyone. The scientific research shows that 1 out of every 4 to 5 people who undergo any kind of surgery, they don't get the successful outcome. They don't get pain relief, and they don't improve, and they don't come out with the same pain relief that they are hoped and anticipated when they submit themselves under the knife. So
Right.
that means it is something we have to say ki bring in the rest of the package. And I'm not saying ki, as you said rightly, we don't want to eliminate it. There is a role for it, but do not disregard the other things. Just bring them also into the picture. And as you rightly said, I have lots of patients now who are able to achieve and keep good quality pain relief by using a mix of these lifestyle strategies, rather than only depending on medications or the next injection.
Right. And, it is just an eye opener for, most of us kind of talking about this publicly in the open. And it's like, you've spoken about it in various forums. Like, how do you take this to mainstream, and how do you change things that you're taught at medical school? Because whatever you're taught there and whatever is the thing to do is continuing, and these are the concepts, like you said, have been age old, but these need to come into the light for people to actually feel the difference and not just go for one thing or the other. So what is, I mean, how do you look at the medical schools being, speaking more about the diet and the sleep and all of that and therapies, and how do you bring about that change?
Change. Easy question to ask and a hugely complex answer to give. Um, what I can say is that optimistically, the green shoots of change are happening now. And it might be surprising to your audience as well. Any of your doctors that you see practicing, the 35-year-old, any medical professional you see in the Indian healthcare system or yeah, UK or US healthcare system, take a wild guess on how many hours or how many days or how many weeks of pain education they would have had in their 6 years of medical school training. Take a wild guess, Soumya. Maybe you've read the book there, but would you be able to take a wild guess on there? And this was a question I will ask your audience as well, and maybe they can put something in the chat box for us to look at. Just I'll give about 5 seconds. Put down any answer, or what do you think? How many hours, how many days, or how many weeks of pain education an average MBBS doctor gets in 6 years of training? UK, India, whatever. If you put that there. Oh, I've got somebody actually saying 8 hours.
8 hours.
Clearly, Dr. or Mr. Venugopal is actually very, very close to the truth. My God, Mr. Chandra is even more closer to the truth there. It's actually a little better. It as works out at 8 to 12 hours of pain education is given over a 6 year period. That is abysmally low for a problem that is 80% of the time that somebody goes to a doctor with is mujhe dard ho raha hai. I have a pain somewhere in some part. Our teaching of medicine and medical professionals on pain, the understanding of pain, is only 8 to 12 hours. So that has to first change. And I can say I'm not sure about what is happening in the Indian medical curriculum, but now in the UK and in US curriculum, a whole lot of the deaneries, the major universities in the UK are ensuring that between the second and third year, they are having a module where they are increasing the duration at least to a week, almost 2 weeks. So that is the first step that is happening there at medical school level. Part of me wanting to write this book is actually there is a top down and a bottom up. You can use the top down approach of saying, okay, let's approach the healthcare professionals and teach them one university at a time, one nation at a time. But these are the days, because of social media, because of me talking to you like this and me talking to other podcasts and so many mediums of communication, I could also use a bottom up approach. And this book represents a bottom up approach of getting that education out in an easy to understand, convenient manner for the general public. And it's available on Amazon, it's available on most of the platforms.
Yeah.
And this is my opportunity to say, okay, this is the first step of the bottom up approach. The second step I'm doing locally now in my area in Reading, UK, I've got something called the Reframe Pain Challenge. So I'm going to the 12th class, 11th and 12th class students. I've got a few schools who have agreed for a challenge where they are going to look at a couple of good websites around the new science of pain. And
Oh,
then
wow.
I'm going to give them copies of my book. And these 11th and 12th class students are going to look at this book, read this book, take in the knowledge, and they are then I'm going to invite them to collaborate with me to say, this is the knowledge I have, I put it in a book. But we know that not everybody is going to sit and read a 200-page book there. Some of them may want a podcast, some of them may want videos, some of them may want the same information in bite-sized manners. So that is the next step of the challenge key. If I can get the 11th, and these 11th and 12th class students are part of the medical societies in these senior schools. So these are
Okay.
going to be the next generation of doctors. So if I can influence them to give them the new science when they are learning biology at 11th and 12th class, then the hope is that when they go into medicine, they will be able to go in with a more curious approach and a better understanding. Because another part of the science jo aata hai na, empathy, what we feel for our fellow human beings, the compassion, the love, and the understanding of pain. Apparently, what you have as a first year medical student, you are down by 70% by the time you reach your fifth year final year student and you become an intern, because by that time
Wow.
you've been grilled so much into diagnose kaun sa dawai, which drug, which surgery, and you become like the full consummate mbbs professional. The empathy factor of caring actually goes down because you're more interested in making a quick diagnosis. And I think there is a lot of move in the US and in the West, and I hope in India as well, that we need to look at getting the people when their empathy is still high to understand that pain is very complex. It's not very simple like the way we thought it is. It is not, we'll go further into the podcast where I can talk about a little bit about it. But we are understanding now that things are not as easy as we thought. And in our attempt, as we can talk about life itself, the more you want to simplify life, the more complex it will start to become. And that is
Right.
what we have understood about pain, as well as the more we drill down to understand what all can cause pain, we are realizing that it's not just one structure. There can be so many things, which is why my book also is about that combination of things that you can put it into a package, the mindset. So that is where that complexity will take time. So it is happening. The green shoots of recovery and change are happening in medical schools, and there are so many people like me across the world who are talking the same thing and doing the same kind of education in every continent. It is probably in the next 5-10 years we will see this becoming more and more mainstream about how we should look after pain patients.
Yeah, and this is something which is like what people really need, right? I mean, there is like you said, I mean, empathy. That is something that people really look for when you meet a doctor or when you visit a doctor instead of just coming out with a prescription.
Yeah,
Yeah, and like you said, like bottom up approach could also be audience like this. Like you do all these sessions, you do all these forums so that you as an individual are well equipped to ask these questions even to your doctor. Like instead of it coming the other way from the doctor to you can pose these questions to your doctor
yeah.
and be well informed about these things also exist. So if you do A, B, and C change in your lifestyle, then maybe I don't need this medication. I mean, it's like a dialogue that you can have with your doctor and spread awareness. And at least as an individual, you should have this awareness.
I think so. I mean, there is a word for that now. We are calling that shared decision making. So every time a patient, because these days the power of Dr. Google, Dr. Google may give slightly odd information, but most of the time, Dr. Google probably has a much higher quality of information that is already out there. And there is this author called Dan Pink, and he writes this book, and which he says actually that the amount of knowledge that is already available in the world via the internet is massive, is in fact too much. And
Yeah.
that can have its own kind of confusion for the general lay person who is reading this thing. So actually the purpose of somebody like me, an expert or a subject matter expert there, and for that matter in any industry, is actually to be able to be a guide, to be someone who can work with this information and help the person in front of them, client ho ya patient ho ya customer ho, to actually say this is the spread of information, but in your particular situation, your personalized matter, these are your options, and depending on your context and your circumstance, these are your first two or three options that you can do out of the sea of options that are now available. And that still requires discussion, talking, and shared decision making, and what we call a collaborative healthcare model. And that is now becoming the way we are approaching care. Definitely, I can see that happening in the UK. I'm hearing that's happening in the US. And I wouldn't be surprised if that is not happening already in India. I think in India, because a lot of our healthcare is still a self pay model, where the public is paying for their care out of their pocket.
Yeah.
They want value. They want to say कि अगर मैं इतना पैसा दे रहा हूँ, I'm giving this many lakhs and this there. They want to know that it is the right thing and it will make it. Sometimes, and I know that it gets a little too excessive, and my colleagues and my healthcare fraternity in India have been subjected to abuse and physical violence. But the principle of it, that we should be engaging more with the patient and making sure that the benefits are understood, I think that is becoming very common everywhere.
Yeah. Right. And you've also mentioned, in your book, there's this term called nociception, and
Hmm.
then we talk about pain. So can you just tell the audience and, kind of talk about what is nociception and how can a person differentiate between chronic pain and,
Acute pain.
nociception?
Absolutely. It is probably the most, the keystone point in my book is
Yeah.
this difference between nociception and pain. And that is what the research now is telling us, ki whenever we feel some injury. So suppose we've had an injury when you're running, when you hurt yourself and you sprained your ankle and it is swollen, and you had a fracture, God forbid, or you have a surgery. So when you have a cut or when you have a break in your skin, the nerve at that area starts to generate signals. The injury means that the immune system will generate signals there. These signals are traveling in the nerves, and that signal is reaching your spinal cord. And from there, it is taking the next bus to go to the brain. So,
Yeah.
this process of the signal that is starting from the place where the injury or surgery has happened, all the way right up to the brain, this whole process is called nociception. This happens in everyone and all of us. Nociception is a primary signal generating mechanism. This is just referring to the chemicals and signals generated. When that signal reaches the brain has to do a lot of prediction and processing. It will see key signal is coming. Where is it coming from? What are you doing when that signal is coming? What were you doing? Did this ever happen to you before? What should you do at this point of time? And its first response for the brain, the primary response is, does it need to protect you? These are the three questions or four questions the brain is constantly asking. Has this signal happened before? What is the signal and where are you? And what do I need to do to protect? This is what the brain needs to do. This processing is going to be informed, therefore, by what are the past experiences, by what is the present context. So if you've had an injury when you're playing football, you might still want to finish that game if you can. But
Right.
if you are having it in the middle of a busy road and a car is coming straight at you, that is a different context. The same injury, the ankle sprain, can happen in both places. The signal from the ankle sprain will travel in the same way, but the context and how the brain interprets will decide how the decision needs to be taken. In one, the protection has to be instituted very quickly and get you to day safety because the car will hit you if you dawdle on the road. But in the
Yeah.
other, it is a football field, so you can still move carefully, move away, or continue playing if the excitement is a lot and you're going to score a goal or anything like that. So, context matters, past experience matters, and finally, the decision that it takes. If it says, it has to protect, that time it will institute the mechanism of pain, the experience of pain. So, there is a very big difference between nociception, the signal, versus the output finally that comes from the brain, which is what we call as pain. And what we have done always in healthcare and the teaching that we have been taught in medicine for the last 300, 400 years is that we have thought ki nociception and pain are the same. We have just said ki
Mm.
whenever you feel something somewhere, it is pain and it must be coming from that structure, and we should do something about it really quickly and not move that part of the body until it is sorted. So that is, now we realize, a flawed understanding, and separating it is important. In acute pain, when you have an injury, often the nociception will be almost equal to the amount of pain, but it is not exactly the same. So that is why a child may hurt itself, and you can get the child comforted by calming it down, rubbing it, or kissing it. But you try to do the same kind of injury to an adult, the adult may not have the same calming down response to rubbing, because they will have a different set of past experiences and
Hmm.
expectations and context. So even in acute pain, there is that separation, but not too much. If you have a fracture, you will have a lot of pain, and it is because most of the signals are coming and the brain is saying, protect, don't move that leg until it is sorted. In chronic pain, however, the difference is quite a lot. People who are having pain 3 or 6 months, for example, back pain, the pain is going on, and they go and get a scan done, and the surgeon will say, Ki, there is some little bit change, but you can't explain and understand why there is a flare up of pain every month, even though you may not have done anything very exciting or physically strenuous. In those situations, what we are now saying is, you may have had an initial time where there was a soft tissue or some injury with that disc or the muscle or the joint or the ligament, but after 3 months, it is the nervous system that has gone into an overprotective cycle. So then nociception signals need not be coming from the disc or the back or the muscle anymore. The experience, the nervous system has learned and is amplifying the response or dampening the response according to a variety of context, according to a variety of other environmental factors, which can still make it think that it needs to protect. And if it does that, it will still bring about the experience of pain because of the influence of context and environment, but not necessarily because of what are the chemicals coming. So that is why there is importance to distinguish nociception and pain in acute and chronic pain. They are two different things, and they have to be managed very differently.
Right. Yeah. And one thing very interesting, Deepak, in your book, like just before every chapter, you've put in these interesting quotes. Yeah, and one of them actually really caught my attention, which is by a spine surgeon. And usually, when you go to a surgeon, he recommends surgery, right? And so the quote is like, the most rewarding aspect of being a surgeon is watching patients go pain free without surgery. So coming from a surgeon, it's actually quite interesting. And what happens is that as a culture and society that we live in, our go to treatment, like we said in the beginning, for any pain is medication. And if it's severe, then is intervention or surgeries. So your book kind of defies that and asks people to look for ways beyond these options. So when do people need medications or interventions, and when do they don't? Because there are times when you actually need them. So how do you differentiate the two?
Uh, Quite an important question. And I think this is still an evolving, challenging point. When exactly is the right time is always a very difficult question to give, because people's reason for pain or the cause of pain can be very different. So I'm not going to say that there is a very prescribed answer straight off the bat. But what I try to bring along, even in the book, I talk about all the stories of people I write in the book and the quotes that I use as well. They're all coming from people who are out there, who have been able to show with scientific evidence or their personal experience how they have managed to either not need medicines or surgery and yet live a pain free life, or at least a quality of life that is very good compared to the pain that they have or that they are enduring from. So, what I want to show my readers is that there is always a huge amount of hope if only you can view things differently. So, this surgeon that I talk about, this David Hanscom, he is an orthopedic surgeon. He practices in Seattle in US, and he has learned it the hard way. He spent the first 10-15 years doing a lot of surgery, and then he realized actually he wasn't getting the success from his surgeries for his patients like the way he thought he would. And that's what made him reflect on his practice. And then he realized that it is important to identify certain patients and certain issues in patients before going for surgery, because then the outcome is not great. And That part I can definitely talk to your audience as well, is to say that we can make that difference between when surgery or medications are the right thing for you or not. So if it is a very acute pain like a fracture or a heart attack or some kind of stomach problem where you've got appendix trouble or something like that, then there is no question about it. You do need medications at that time, and it is definitely, you might need some form of a surgical intervention to stabilize the fracture or remove the appendix. We are not denying that. But when it comes to arthritis, when it comes to chronic pain coming from the back or the neck, then I am encouraging all your audience and my readers to actually just read the book, or at least to understand a little bit more about yourself, what your present circumstances are, what is the level of stress that you're under. Would you consider yourself to be having a diet that is healthy or not? What are the implications of physical activity and mind body therapies? Because we know that all of these can adversely affect the nervous system, and they can make your pre existing pain experience much, much worse, even though there isn't any structural problem going. So, that is the invitation that I would give to your audience, rather than to come up with a very clear find. What we do
Mm.
find from the studies that we are doing and looking at is, if people are quite worried, if there is that heavy anxiety element, if there is a lot of weight related issues there, or they are having medical problems like diabetes or asthma, which is poorly controlled, or if there is a lot of stress. So these are the top five. Lot of stress due to a variety of emotional or physical issues going on, then that may not be the right time for surgery, because the nervous system is so wired up for threat already. When you then put your body under a surgical
Yeah.
strike of any kind, that amplifies the threat so much that your outcome is not likely to be good. That much we have got the scientific evidence to say that now. So that is all I would say is, if you still decide you like your surgeon, you have had this discussion with him or her about the benefits, the risks of surgery, then can you ensure that you give yourself that 8 to 12 weeks to optimize yourself, to work on the diet, the sleep, the physical activity, the mind body therapies, your understanding of your anxiety, your stress elements. And then when you have optimized it, go for whatever drug you want to take, or whatever injection or surgery you want to do, because then you have given yourself the best chance for success.
Yeah, and it's so interesting because, why would anyone want to go under the knife if you haven't actually explored all these options?
Yeah,
And if someone says like a surgery, you're already anxious about the whole thing, and the anxiety heightens,
yeah,
through the entire
true.
process.
It's a
Yeah,
very
so
cultural thing as well. I
yeah.
see that in the UK when I'm doing my pain clinics, when I see Asian member coming through, I think there is a cultural impact. They come through because they don't want to go for surgery, because that's too dramatic and too high for them, a high value stake that they don't want to do. But I see there is a slightly different cultural shift in the Western population, where they are more accepting that, yeah, I need surgery. So, you know what, let's get it through. I want to go for surgery quickly. And my discussion with them is slightly different. I kind of tell them,
Hmm.
do you want to do these things before you go for surgery? Whereas in the Asian population, it's a little bit of an easier sell for me, saying, okay, I know you don't want to do surgery, so let's do these things. So it's interesting to have that conversation, and I think there is a cultural element in how we grew up and what our worry is with surgery. So you're absolutely right.
Yeah. In fact, we have some interesting comments and some things. I'll just put them up. Can doctors understand that height of pain? I sometimes have cried in front of my doctor as it is unbearable. Or is it that doctor knows there are no solutions to my knee pain due to rheumatoid arthritis and he does not want to recommend injection or steroid?
Seema, that is Very good point you make, and I wish I could say different. However, I would probably say it's going to be a mix, probably the second one, latter one. The doctor, if your rheumatologist or this one knows that a steroid is maybe unsafe to give, because पंगा है ये है कि steroid as well, we are realizing that if we give it more than 2 3 times a year, it is going to cause joint or muscle degeneration faster. So there is a limit on how much you can do and how often you can do and how much you can put in each time when you do. So I think that the doctor realizes there is no solution from the medication or injection point. However, there are other options that people can suggest for rheumatoid there, and that's a discussion he or she could possibly have with you, which is what I talk about in the book. There is with like conditions like rheumatoid, just you have said, we know it's an immune autoimmune condition, and in there the immune system is almost interconnected and hugely influenced by the nervous system and influences the nervous system. So there are opportunities now to actually say ki you can influence the immune system very nicely through nutrition. So there is a lot of focus on saying that for an autoimmune diet or an anti-inflammatory diet can actually help in reducing the rheumatoid arthritis intensity of pain that you get when this inflammation happens by up to 30 to 40% when you put in the same dietary measures, which is almost the same relief that comes from a steroid injection as well. So there are opportunities, but that because again, nutrition is not a subject that is taught to doctors at all.
Yeah.
We don't get any, not even pain, समझ लो, at least you get 8 to 12 hours. Nutrition, we don't get anything at all. We just don't learn anything other than in biochemistry. We learn about vitamins and minerals, but nothing else after that. So that is another topic of the next book.
Yeah. Yeah. Another question, Deepak. Do you think that doctors in general take women's pain less seriously? This has been the case in my own experience and in many other women whom I know.
Yes, you are right about that. I think there is an institutional and systemic bias there, and it's a lot of reasons on why that happens. And I think it's almost unconscious bias. This is not something that is deliberately done. I think it's unconscious, partly because we just don't understand sometimes. Until 1970s, it was very difficult for any clinical trials and research to have lots of women in. So a lot of the studies up to the 50s and 60s have had only men as subjects. So I
Mm.
think there is a fundamental scientific issue that we haven't really explored women's pain properly. What are the hormonal and other impact and influences and reasons for how there is a gender? And we now understand that there is a gender difference itself in how pain is amplified and perceived. My thinking is fundamentally pain is about a protection mechanism. And at an evolutionary level, is it important for the female of the species, which is responsible for procreation and the survival of the species, is there more importance for them to be aware of threat and institute protection more often? So this is a topic that you may find a little maybe interesting, maybe confusing, maybe anger provoking, but it is something to think that is that a reason? Because chronic pain, they say, is more often seen in women than men. And if we think that pain is a protection mechanism and an overprotective mechanism, is it possible that at a species level, there is a reason why the female of the species needs to have a higher level of threat mechanisms awareness? So maybe that's one of the reasons they're speculating as to why women have chronic pain. But it is true that doctors do not get that appreciation of the gender issues there. It is not researched well enough, and therefore it is not presented well enough. As a side note, I will tell your reader there was an article that came out in one of the scientific journals in March of this year. And these researchers had a very interesting idea. They wanted to look at animated movies like, Incredibles, Toy Story, Pixar,
Right.
all these Pixar movies, And their interesting project key was they saw 50 movies like the Dora, Princess Sophia, everything that we show our kids on Disney Channel and all these things. And they wanted to look and see how often is pain represented in these animated movies, and which kind of characters suffer from pain most, boy characters or girl characters.
Wow.
And they did 50 hours of looking at all these movies, and you'll be shocked at the results there. Pain was shown apparently 80, every 9 times in an hour. They were showing characters suffering from some form of pain. Chronic pain was never shown at all. Almost always it was acute or procedure pain. And this is the shocker there. Boys were shown to be suffering. Male characters were supposed to be suffering from pain. Girl characters were never shown to be suffering from pain. And the second most shocking thing, every time this pain happened there, in more than 70% of the time, the other characters who were witnessing that pain showed no empathy, did not
Oh,
really respond too much. तो समझ लो कि if this is the unconscious and subconscious way that we are telling our children, and if you believe that media is capable of influencing public opinion,
right.
then here you are showing your children, our children, all of this literature and all of the staple of Disney movies. But this is how Disney and media is portraying pain at a subconscious level. So, what do the boy characters and the children who see these movies, what are they going to grow up with? Their perception is going to be that girls don't suffer pain because हमने ये तो देखा नहीं है, and their perception is चलता है, any pain is all right, they'll get better. It's after all हो जाता है.
Yeah. So, how fascinating. Could you give us the reference to this study?
Yeah, I'll give that to you at the end there. It's Malwari et al. It's a Canadian study there, but I'll give the referral to you.
Sure. Yeah, this is interesting, Deepak, because in India, they have these various movies and ads that kind of do the rounds, which says "Mard ko dard nahi hota," right?
Amitabh
And this is
Bachchan's
like,
legacy.
yeah, and this is like, this is like actually showing something else. Like women don't feel the pain in
Yeah.
those movies, at least, or yeah. So this is also very interesting. Yeah. Yeah, then I think we'll talk about therapies a little later, but we have a question. How can we use alternate therapies like essential oils when the mainstream doctors do not recognize or recommend them?
Um, there will always be this disconnect between mainstream medicine and some of these therapies. There is now a push for something called as integrated care, and a lot of this is coming up in the US now and some of it in the UK, where they are realizing if you want to give value and you want to do something like value based healthcare, you need to integrate some of these alternate therapies or complementary therapies, as we call it, along with what we're doing mainstream. Because what you want to give is something that is relatively safe and not going to harm, and accept that they may never have the level of evidence that you require to give it.
Right.
This is something that is difficult for many doctors, and most often the surgical specialties or other specialties to wrap their head around, because for almost 6 years you are drilled key evidence, high quality evidence रहना चाहिए. There should be a study that does, you should have one group that is getting the intervention and
Hmm.
another group should be a control group, and you should compare with these two groups, and a study group may, if the intervention is this much more effective, that means it is a high quality study, and this is called a randomized
Hmm.
controlled trial. So these are the bedrock and the foundation of studies that are done for any drug or some procedures and all that stuff. But for essential oils, like your audience member asked, it's very difficult. How can we get 100 people who will get one dummy essential oil, and then another 100 people will be given the true oil? And how are we going to test it? These are difficult to do, and there is no paradigm for doing it. However, the amount of money it will take to do a test like this, the oil itself will not cost that much.
Right. And also the time taken for any
And the
research.
time taken, it takes about 1 or 2 years for a good, pharmaceutical companies ke paas paisa hai. They have a huge amount of reserve that they can put money into generating and doing the result. It might be again a side fact there. Companies like Pfizer and all these other big pharma companies have estimated that to get a good quality drug from the time they research the molecule in the laboratory to finally one packet that comes in the
Yeah.
consumer hand, it takes somewhere between 5 to 8 years and up to $2 to $3 billion.
Oh,
That is the
wow.
amount of money that has to go through the research pipeline for a successful, and this is all the regulatory hurdles ko par karke aana. So to expect a manufacturer of an essential oil to be able to be having the deep pockets to fund that, to show that this essential oil is like the bee's knees and this is must have and it can defeat anything else that is presented, is a very tall order. So
Yeah.
that is unfortunately against the essential oil or complementary therapies, Ayurveda ho, ya Reiki ho, ya acupuncture ho, ya homeopathy ho. That is the struggle that they will never be able to fit into the paradigm of how we look at drugs and injections there. It is going to be always difficult. And as long as that divide exists, mainstream doctors are likely to look and say, ki when you compare a tablet to an essential oil, they cannot recommend an essential oil because they'll be worried that somebody will tell them ki you cannot recommend non-evidence based things there. So they
Right.
will say, ha, drug le lo because it will definitely work, but you can consider an essential oil. And I think that is changing now with this value based system, wherein we are saying we want to give something that the patient is able to feel safe and take on board and use. And so while you can give something evidence based like a tablet, you can also make a good recommendation about a diet or about an essential oil or about a mind body technique, because as long as safety is there, the nervous system can calm down and that can mean pain can be improved.
Yeah, and very interestingly said, Deepak, because it's like so much research, and obviously these alternate therapies don't have so much backing them like the other medications that we get, and it'll take years and of time and money to actually get that going. So obviously it kind of gets sidelined and doesn't kind of come in the main this thing, prescription.
Yeah.
But as long as people are aware, I think it's worth a try because it's not going to harm. So try all these alternatives before you actually go into something big.
Yes, I think that definitely would be there. And I would also say that there is no harm in actually continuing it. Have that discussion with your surgeon, because if you feel, or your physician, if you feel that doing a meditation technique or doing some essential oil balm application is helping relieve 10% of the pain, but you feel fairly convinced with your physician that that next step of a new fancy drug or a surgery is also to be done, there is no reason to say one or the other. You can combine both.
Yeah, right. And yeah, another interesting thing that I saw, yes, I think it's a good idea that each one of presents this book to our favorite doctors as a gift, especially in India.
I'm never going to say no to that. Thank you so much.
Yeah, I think it's just like, to like bring about awareness that here, read this and then do your consultations.
Yeah, it's for what one of my, when I presented to my alma mater back in Jipmer in Pondicherry, my medical school where I did my MBBS and MD. That's what one of the profs actually said. Yeah, we should have this. We should think about getting this and giving it out there. And certainly that I think is a theme that's come out here as well. So I'm very thankful to a lot of people who have thought like that. So thank you.
Yeah, I think it's a personal question, but I'll just take that up. My mother-in-law has been diagnosed with, I don't know how to pronounce that, Deepak. Eh,
Diquervent science. Yeah.
Yeah, the treatment is surgery or steroid shot. The pain is unbearable and it gets in the way of her regular work. We are opting for surgery. What do you think about this not so common condition?
So both of them are, the steroid shot. So I have done, I patients get referred to me for steroid shots for Dickerwens, tenosynovitis. Essentially it is a small inflammation in your wrist of one of the ligaments and muscles that have got strained. And I would generally just say, I think in the initial part, Soumya, you said I'm an upstreamist.
Yeah.
And I would like to go upstream on this to you, Seema, to actually say, okay, you might say that you've now reached the point that it is going to be a steroid shot or a surgery, and both of them are fine. Surgery mein kya karte hain? They will strip the lining which has got inflamed and hope कि अगर lining को निकाल दिया तो ना रहेगा बांस तो ना बजेगा बांसुरी. So that is the hope that they will have. A steroid shot is the same thing because it is an inflammation. You give a steroid, steroid will be anti-inflammatory. So maybe it will be. So both of them you can see are logical as a action plan to take. The question to ask is the risk of surgery or the success of surgery is not 100%. So that means you have to say ki, what are the ways you can do to make this ideal for surgery and what were the risk factors in the first place. So there are many things. We know that decurvents, there may be things like diabetes or hypertension or weight related issues. There may be a thing that a lot of housework is being done with a particular kind of posture, and that repeated weight posturing is what causes the strain on this tendon and ligament to go into inflammation. So is there ways that you can look at how to adapt the posture, reduce it, allow for it to heal there? Is there a chance that you can include some dietary modifications to reduce the inflammation that is happening at that level rather than a steroid shot? So I think that there is scope and opportunity for at least 6 to 8 weeks of going full force on looking at those other, the N, the D, the S, the E, and the T, and then saying, you know what, chalo, ye sab kar diya, or we've got a plan to do all this in place. Let's go strip the lining and see where it takes us. At least we've got a before plan and we've got an after plan to get the best back.
Right. So basically people need to give themselves time and patience, because these alternate therapies take time. So you need to give it, some time to actually see the benefits and then decide and say, okay, this is what I've tried. I've done my bit. So maybe the person doesn't need to go for surgery. Who knows? And
And I
or
know.
if needed. Yeah.
And I would say आसान है. मैं यहाँ पर बैठ के ऐसे गप्पे मार रहा हूँ and we are saying this, 2 6 weeks waiting करो, but the person suffering in pain is the person
Yeah.
suffering in pain. So I am not going to deny that what are the impact on her mood, what is that affecting the household, how that is changing, how she thinks about herself and the ability to not do the work that she is
Yeah.
doing all the time. So ये सब चीजें, they are undeniable and that may make some people make them decisions earlier. But if you're going to give 10 to 50,000 rupees and you're going to put yourself through putting in a cast for 3-4 weeks after the surgery and you go for that, what's the best thing you can do for your self-care to make sure that is the ideal place and time to do that? That is the question I would want to leave your audience to think with is, with any intervention, what can you do for yourself that gives you the best chance to come out of it with the best success?
Yeah. And as the name says, right, mind body therapies. I mean, your mind is so strong. And, that's like brings me to the next question on your gut being the second brain. I mean, when I read that, I was like, this is so true because I could relate to it myself. And I know friends and family members who can also relate to it. There's nothing wrong with your gut, but there is a connection with your brain and the gut. So like you said, gut is your second brain, or every disease begins in the gut. So how are the brain and the gut related, and why is it that most of the time there is nothing wrong in the gut, but if your brain isn't responding positively to a situation, it creates gut problems? So that obviously kind of brings to the point that what role does diet have in being pain free and the
Right.
whole brain and gut connection?
Excellent question. And to me, that, like in the book as well, that chapter on the diet and microbiome is the second biggest chapter after the understanding of the nervous system. And to me, this was like, it was mind blowing for me or gut blowing for me when I heard about it about 4 years, when I started reading about it 5 years ago and realizing that there is this whole branch of medicine which I never had the opportunity to even think about. And yes, sub in the last 10-15 years is how we have understood this better, and the science has really made huge leaps and bounds. And it fundamentally boils down, if I can tell your audience key, why is it so important? And the thing is, 80 to 90% of our immune system जो है is along our intestine. And this will be surprising to a lot of people, and it was surprising to me to think I always thought my immune system was roaming around in my circulation, or it is there in my spleen, or maybe it is in the bone marrow, because that's what we studied. These are the cells, white blood cells, and ये सब तो वहीं से आते हैं, that's all. But most of our defense forces are at the border. They should be. And the border, as far as the body is concerned, one border is the skin. But the other border, if you think about it, is the point that starts from the point where you put your food in the mouth right through till the back passage. That is the other border, and that border is only one cell thick. Imagine a wall with just one brick layer. That's
Yeah.
all you have. And therefore, you do need your immune system and your defense armies to be on the other side of the border, because that is only a thin lining. But what the human body has done over years of evolution, over millennium or centuries of evolution, is they have had to adapt. If we think, and you are subscribing to the Darwin's model of evolution, that we have evolved from there, that means these bacteria, these other organisms have been there before we came along the picture.
Yeah.
That means when we grew up, they were already part of us in a way, because they co-evolved with us. And that is the discovery that has come with us, that on this side of the brick wall is all the lining of the bacteria, the organisms, the small fungi, some kind of viruses. They are all living with us. There are some good bacteria, there are some bad bacteria, and they have an ecosystem where they balance each other out and they stay. And there is a constant communication happening between the defense forces. It's like, you have your share of little bit of spies who are
Yeah.
located in there. So the defense forces have this constant communication through the single barrier there with the bacteria and the various microorganisms that are there on the inner side of the wall, that is the intestinal side. And they have been there right from birth. In fact, this is again will be interesting to your uh, audience there. When they looked at breast milk, there are some chemicals that the mother produces as a breast milk, first part of the breast milk that the baby has, that are actually not meant for the baby at all. That is meant for the bacteria that is there in the baby's intestine, because that bacteria will break down that part of the human breast milk and use it to nourish themselves and grow. And you might be saying, well, where is that bacteria coming from? Which is why we now realize that vaginal birth, when a baby is born by normal delivery, that first inoculation of bacteria comes when the baby is coming through the vagina. That part of the bacterial population there is the first dose of microbiome that enters through the mouth and goes and settles down in various parts of the baby's intestine through. And they are saying that sometimes when you do cesarean section, there is a slightly higher chance of children having some autism or those kind of problems, because you are denying them of the vaginal microbiome and the influence of this good bacteria when they're born. So actually there are some hospitals in the world now where when the baby is born by cesarean section, there is one midwife or one nurse who will take a swab of the mother's vagina and keep it ready. And as the baby comes out of cesarean section, they will do a nice application on the face of the pad or the swab that has been soaked from the mother's vagina onto that, just to give the baby that benefit which it has lost because of coming out from a cesarean section. That is the importance we're realizing now of this bacterial population, because the genes that come from the bacteria or from the fungi or any of the microorganisms in the intestine, they are working alongside our genes to make us a superorganism. So they are
Mm.
already our pets and our people who are living with us and inside of us, constantly looking out for us, destroying a lot of the stuff that we eat and making sure that we are as healthy as possible. And unfortunately, what we have done in the last 30, 40 years of the processed foods is we are giving so much inflammatory stuff by eating processed foods and sugary foods and sweet stuff and all of this stuff, that we are overwhelming the good, healthy bacterial populations and the microbiome populations and allowing for the unhealthy microorganisms to proliferate and survive. And if you think about it, Ajkal, the investigations you do for the gut, whether you do a CT scan or MRI or colonoscopy or
Hmm.
endoscopy, that is never meant to pick up a problem with the bacterial population. It is only meant to pick up what looks inflamed or swollen or a tumor. It can never pick up this really microscopic level of
Right.
drama and ecosystem going on. But this is the drama and ecosystem we can actually influence, because this immune system is talking to our nervous system, and it has got a separate highway connection going to the brain and the gut. And so the nervous system in the gut and the immune system in the gut is almost it is almost the same number of neurons and nerve cells like the brain, and they have an equal function. Because if you think about it, हमारा brain जो है is in the skull. The
Hmm.
only information the brain is getting from is what it sees through the eyes. What it feels will be still nerves that come from the skin. But the other biggest source of information for the brain to make decisions about the outside is actually coming from the gut, what the immune system and the nervous system in the gut is telling. So that is why this second brain concept has come, because how you influence the second brain can actually make a bigger influence into the first brain, which is the first one in the within the.
Yeah. Yeah. Thanks so much for that, Deepak. I think we have another point. I think we are going to talk about sleep next. So we are on the S of the word mindset. So we will talk about that. And obviously, there have been sleep actually is like the most talked about subject today. And there have been various books written on the importance of sleep. It's a subject which has been neglected for years, or rather, not spoken about it for years. And at times, it's a vicious circle. Like, we know we need a particular number of hours to sleep, and we need to give sleep importance, which we tend to not do. But if someone is in pain, and the person cannot sleep, or you need to sleep if you are in pain, so it's like a vicious circle. So how can you use sleep as the next topic to talk about in your favor, to heal that pain?
This by far is been the most challenging chapter to write as well. And I think even in practical application for patients, this has
Yeah.
been the most difficult for them to do, because the evidence is now absolute that the pain and sleep, we always thought ki agar if you have pain, then your sleep is affected. We understand
Yeah.
that part. But now the evidence actually is the other way around, that if you are having disturbed sleep to start with, your nervous system is already sensitized and threatened. So it takes very little, it can be a very mild injury that can then set off chronic pain. So actually, we are now realizing that paying attention and optimizing sleep by whatever method possible is worth it, because it will calm the immune system and the nervous system down more efficiently. And by having a better quality of sleep, you're allowing for the immune system to function better, allow for the brain to do its housekeeping and cleaning activity. So actually, now sleep is primary when you're
Hmm.
trying to even treat pain. So even before you can get pain, if you want to reduce your risk of chronic pain, now for those of your listeners who are not in pain and doing their, pay huge attention to how you optimize your sleep and get it in the magic place between 7 to 9 hours. That is what I would say as the first step. If you are not in pain, please make sure you do that, because when you go through disturbed hours of sleep or less than 5 hours, you're setting yourself up for that risk of getting pain when you get some other problem. That is a sure shot. Now, with the pain issue there, it is going to be a tricky point there, because once you have pain, there are various ways of trying to improve your sleep. Again, like most of us will say, let's take some medication.
Yeah.
The unfortunate problem now that is shown is that the traditional 2 3 drugs that have been approved in the world for improving sleep are also dependence inducing, and worst case we have realized now that actually they increase the risk of death by other problems. So
Oh,
actually
wow.
dawai and their tablets for sleep are almost a no go. If you want to do it for 2 or 3 days because you've got jet lag or you've traveled and all that, then maybe yes you can. But there is a lot of attention in things like melatonin, and there is a lot of attention in looking at how you can use diet and nutrition again. So when you eat, what time you eat, how much time you've given for your digestive system to digest certain foods, and how much time you're given for it can all induce sleep faster. How much coffee you take, when you take alcohol,
Mm,
whether you can reduce that, can change the sleep pattern. If you can almost teach your brain. So, because we think that if the brain is already wired up, how much of mobile signals, the blue light that we talk about,
yeah.
all of these make the brain think that there is threat. So if you can actually reduce that level of threat and say this is a new habit, as this time approaches, you will start to do these 2 3 things. You will take a warm bath, you will have some valerian tea, you will have time where you de stress, where you read a book, where you calm down, where you go to your room, lower the lights, like the way you want to get your child off to sleep. You
Yeah.
put them in a room. When you can do all that in a sustained manner, almost teach the nervous system that it is all right to calm down, then sleep will automatically follow. Melatonin is a medicine that has been suggested to kickstart the process, and that has been quite popular now in US and probably in India, has a way of kickstarting it, but it is not going to achieve it. So, like the way to think about melatonin is it's like the starter's gun when you're about to start an athletic race. All the melatonin does is says ki gun has been fired, pistol shot ho gaya. So now you can start the process of what you do
Yeah.
to get to bed safely, but it is not going to put you to sleep. So it's not going to make you drowsy. So I think using that combination of other aspects, nutrition, physical activity, reduction in alcohol and caffeine, and timings of food can all be the 2 3 steps you do when you are in pain to almost teach the nervous system to calm down, and then try to use some appropriate other pain strategies, whether that is rubbing, desensitization, relaxation, breathing techniques, all the mind body techniques to reduce your pain so that you can push your nervous system to safety so that it can rest.
Yeah. And I was actually like listening to this interview by Matthew Walker, where he talks about, that a sleeping pill actually it might help you. I mean, you might go to sleep, but the benefits of sleep is not derived from that pill.
No, no,
It's
that
not that you slept, so I've got the sleep. So that pill has not given you the benefit that a regular normal sleep without that pill would have given you. So then what's the point?
you're very right, Samir. That is, I really liked Matthew Walker's. I would recommend that Why We Sleep book for your audience there to read. It's
Yeah.
fantastic there. And that is, you're right. The drug, Johanna, I didn't go into that part there, but we all know that there are these phases of sleep that we have. We have this uh, REM and NREM, like two phases, shallow
Yeah.
sleep and deep sleep, and the drugs are quite good in kick. That's why you can do them for 2 3 days. But what they do beyond 4 or 5 days is that they reduce the amount of time you spend in deep sleep. They push you to shallow sleep, but they reduce the amount of time you spend in deep sleep. And what we have realized now is that deep sleep is the time when your body activates your cleaners to
Hmm.
come and wipe out the dust and the dirt that has accumulated in your brain and your nervous system during the day. It is the deep sleep phase where the maximum cleaning occurs in your brain. If you don't have the deep sleep time, then that clearance is incomplete. So that is why the drugs are not recommended in the long term.
Yeah, so basically the drug will reduce the deep sleep, the cleaning part, and you feel as if you've slept, but actually it's not helping you.
No.
So,
So over
yeah,
time, your tiredness will still stay. You will still feel fatigued, and you will have some of those issues of what you might feel when you are sleepless, but it will be a problem.
sure. Thanks, Deepak. And moving on to the E part of the word mindset. So, how can someone, I mean, people are, now more aware, people are, exercising, being more aware of it, going for their walks and doing whatever form of exercise that helps. But if someone is in pain, then it's difficult to actually get active if the person is bedridden or if the person has pain in the knees. So how can that, for example, if someone has knee pain, so how can the person actually get the exercise part in their schedules?
So physical activity, what has come out in the evidence is it is something, if you can do a physical activity that feels safe to you, and you can do it for at least 15 to 20 minutes in a day, minimum to start with, or just to start with, that actually builds new nerve cells in your spinal cord, in your brain, and that can be trained to be more safer in doing that particular activity. So that is the first thing about the importance of physical activity and the benefit. Now, coming to your question about, for example, particular kinds of pain, knee pain or back pain there.
Yeah.
The question to understand is, what is the knee pain due to? Now, if it is going to be because of an acute injury like a muscle tear, then yes, I'm going to also agree with you that you may have to rest it in the first few days, take some anti inflammatories to calm it down. But once you've gone past the acute phase, or it is like arthritic knee pain, then what we are realizing is that it is the protection mechanisms around the knee and the nervous system that are the bigger challenges. So when you are then getting a flare up of pain, it's
Mm.
not because you are going to do further damage to the knee, it's because the system has got ready to protect you. If you realize the difference between the old belief, jab dard ho raha hai, it is something happening, I will just not do anything at all, then that is a mindset that is not going to be helpful for someone wanting to do physical activity. So that is where I stress key, let's go upstream. Let's understand what is your knee pain due to. And if you understand that having that bit of arthritis is not damaging there, it is an age related change, but the pain is coming because the muscles and ligaments around it are tight. They are trying to protect. That means, can you start with something gentle, as in you can just be seated and do some extension bending of the knee?
Yeah.
And that can be a simple start. Even 1 minute you can do to calm the system down. Next day, go for 2 minutes, and you start a new habit wherein at least you do some movement. There is now some suggestion and there is research going on that people can actually put on a virtual reality headset or goggle and try to do a game wherein they try to do the same movement while the brain is distracted. So
Right.
then they are able to find. So there was this experiment done wherein people were having neck pain and they didn't want to do these movements of exercise because they were afraid that if they feel the creaking noise, they will have to stop because dard zyada ho raha hai. When they were then told to put on a virtual reality headset and they were told to just walk in a virtual room, they were able to see that because they were looking at the room, they were looking at the other side of the room and trying to look like that, they actually were achieving full neck extension or movement once they had the virtual set on. So I would say that there are now these opportunities where we can help people with knee pain or hand pain or elbow pain, these are kind of arthritic pain. We can use these distraction mechanisms to achieve the movement. And where that is not available, you can still kind of close your eyes, and this is fascinating. This is what athletes do. And maybe as a runner yourself, you probably are aware of this term and your audience is looking. There's this thing called visualization,
Yeah.
wherein you visualize yourself doing that particular activity.
Right.
And that is what athletes apparently practice many times in their head, so that on the day of the actual race or the activity, they can almost, their nerve cells are wired because they have imagined the situation. So this
Right.
is something we can also tell that as a starting point for somebody with knee pain, just close your eyes and visualize how it would be when you keep bending and moving that knee there. And that might be so for someone who's so afraid of pain, you can actually start with a very gentle visualization technique, start with movement there. Then the next step is to put a bit of strapping on and a support to give that protection and assurance, then do some bending, then reduce the amount of strapping and start to do a little bit more without that strapping, and then start to do some walking in a level place where you know all the parts of the room. It's a level floor, you're not going to get any nasty bumps. Go to that. So it's a question of retraining the nervous system to not go into
Hmm.
threat mode, and that is the way I would encourage and talk to my patients about reintroducing physical activity. But the advantages of what it does, I think my book will really probably, hopefully, should give that idea that there is a very good reason for incorporating any form of physical activity back into someone with chronic pain.
Yeah, thanks for that, Deepak. So, just coming to the last one, Deepak, if you can just briefly touch upon, what are these therapies, and you could just talk very, very briefly about them so that at least the audience has a starting
Mhm.
point
Huh.
to think about.
All I can say is that I talked about 31 mind body therapies in the book there. I have tried to look at everything that has been mentioned where there are some studies that show that it has been useful or helpful for pain management. So that
Yeah,
is my scientific focus on that. So there may be other mind body techniques which our Indian colleagues are doing, which I have not written in the book. But the reason I've not written is there is not a good enough evidence that my publisher said we can put it in safely. So there are
sure.
some other techniques I know, but the ones that I've written there are all ways of calming the nervous system down. So the fundamental principle, and this is where I leave your audience at, is the fundamental principle is we know that the mind and body are connected. We know that every thought that we have creates an emotion, and that emotion will release chemicals which will go to our body muscles there. So therefore, using that mind body effect by calming the nervous and the immune system down by using any of these techniques. So there is no one clear technique that is
Yeah.
super awesome as compared to some other technique, but it is what technique has helped for you in the past. What technique do you think it is safe for you to start will be the one that you go for. And at a more practical level, I talk about in the chapter about how far away is that person who's going to help you with the technique. Some techniques you can see on a computer and do it yourself. Some of these techniques, like physiotherapy, somebody has to do it with you to tell you. And some techniques like massage are like done for you. You just lie down there and somebody does it for you. That choice is yours as to which one you want to go for. And that will be dictated by economy, by cost and proximity, and what insurance covers. So I have tried to clarify that for you. But the basic principle is how do you calm the nervous system down? And the evidence is there to say कि जो भी mind body therapy ho, if it calms the system down, the nerve circuits will settle down and your pain will feel better.
Yeah, I think people just need to start trying these things, or they must be already knowing it, but I think coming from someone like you kind of reassures the fact that it will work.
Yeah, I think definitely that's what I would
Yeah.
suggest and recommend.
Yeah. And just one last question, Deepak. I was really, wanting you to kind of talk about just one example of any of your patients who've come to you with a lot of pain, because there are multiple examples in your book. If you could just talk about any one example where someone, so that I just wanted people to relate to real time people who have chronic pain and who've come to you and they've tried everything of medication and interventions. And what did they do differently and how did they actually cope with it? Any example?
Yeah. So one of the examples, I mean, in the book, there are, as you said, there are about 7 or 8 examples. Two
Yeah.
of them are my patients that I had. One was with migraine, and the other one was with widespread pain there. In fact, the one example I can give is this young lady in her mid 20s, and she started to have what was considered to be a rheumatological problem there, lots of pain, multiple areas of the body there. The pain got so intense that She was afraid to move. She was getting these different opinions from her specialist there. So by the time she came to me with her parents, she was really struggling. She was on lots of medication and she was really confused about what to do for her pain, where to go for it. She tried some things here and there, nothing had really worked. And that's where I kind of sat down and literally almost the elements of the book. I reassured her, first of all, with some tests and some investigations to say, look, there isn't any obvious structural damage going on. That empathy factor there to say, yes, you have got the pain, but this is how your signal is processing, how much of it is nociception and how much of it is the experience of pain. We were able to identify what are the other factors going on, the stressful job that she had, the two jobs that she was having. There was an issue with some relationship things going on. She had changed house recently and she was doing up some extra personal.
Yeah.
So we identified these factors there and we looked at what the foods that she was eating there and how in a hurry to get all these parts of her work done, she was going for microwave stuff or eating out on most days. And we really sat down and said, okay, just give me 8 to 12 weeks. All I need you to do is to focus on this. First of all, not be worried that you are causing some damage because you're having all this pain. Start with these small steps of working on your sleep and working on a bit of physical activity and making sure that your diet is starting to get healthy, and then start to get back to doing what you love. Interpose it with your work role. So over the next 3 to 6 months, it took her about 3 months there, she decided that she wasn't going to go for one particular kind of knee surgery that somebody had suggested for the knee part of her pain. She undertook these examples of using a bit of nutrition, working on her sleep. She had a horse that she was very loving and she wanted that equine therapy. So she went along and looked after the horse and got up in the morning. So that became her habit. She'd get up at 6 o'clock in the morning. And in order to get up at 6 o'clock in the morning, she would go to bed by 9:30, 10. So she would change
Yeah.
everything, like the keystone
Work
habit of
backwards.
it
Yeah.
changed, work backward. And that effectively meant she had a morning which started nice. She had a diet, she had a breakfast, she knew what she's doing. And then she was able to go back to gentle jogs by the third month. And by 6 months, she was able to keep a long period of running going. And I think in about 9 months or 10 months after the first visit with me, of course, I added some medication. I changed a little bit of a drug. So it was not, again, only all these
Hmm.
mind body therapies, but it was a combination of mainstream medicine, talking about these treatments and focusing on. But 9 to 10 months later, her medications were very small, but she had a set routine and she completed her first half marathon. So, that is like a high flying positive example that
Yeah.
I wrote in the book.
Yeah. Yeah.
But there
Yeah.
are so many other people who have achieved a variety of their personal goals that they want and made positive movement there. But the aim is to bring the package together, not to just get stuck on the M and the I.
Right. And this is so comforting to hear. And that's the reason why actually I wanted you to talk about, a real life example. And this is just one of them, like you said. There are multiple that you mentioned in the book so that people do realize that, sure, there are medicines, but look at it, in totality. Look at it as a complete thing of how you need to approach a certain thing,
Yeah.
where your medication might reduce, it might not go away, but it might reduce if you incorporate it completely. But this was a very good example, and yeah, very comforting. Just a few comments that I would like to put up, that people have been really enjoying the conversation, doctor. It's yeah, it's you are an encyclopedia of knowledge.
Thanks, Ajay.
And thank you for being compassionate. Wish you had a few pain clinics here. I would have enrolled.
Hopefully, there will be people who will be able to take up what I'm writing in the book there. And I think I presented to a couple of my pain colleagues in Bangalore and Pondicherry, and they were going to take some of these ideas and put it as part of integrated pain clinics. So who knows? Next 5 years, watch
Who
this
knows?
space.
Watch this space. Then, yeah, sleep that soothes away all our worries from Macbeth.
Excellent. Very well said.
Yeah. And yeah, so these are some of the things. And I think one last question before we sign off. Do dreams reduce the good effect of deep sleep? How to overcome bad dreams?
Great question, Mr. Venugopal. I think I wouldn't probably know how to overcome bad dreams. I'm not sure that part there, but dreaming is actually very, very good. If you read Matthew Walker's book of Why We Sleep, he gives a very different explanation as to why we need dreams. Dreams are necessarily the way for us to archive our previous day's experiences and store them away in the right category. The way to think about it is at those times of cleaning that's going on in the deep sleep time, your brain is like the librarian who's taking all these books which are thrown away in different places and is using that time to find the right shelf, the right way to put it in the right place so that it can be found later and retrieved quickly later. So that archiving and retrieval system is what constitutes our initial part of dream starts. But most of our dreams, if you think about it, doesn't occur in the deep sleep phase. It's in the rapid eye movement. The shallow sleep phase is where our dreaming occurs, and a lot of it is assumed to be very necessary and therapeutic for us to process our experiences so that it does not leave behind residual thoughts or emotions that are unprocessed, and that can happen the next day and it can release. So once you have those thoughts, that will release chemicals and emotions and cause our muscles to tighten up. So I think I haven't figured out how to overcome the bad dreams per se, but I would probably be saying that that dreaming aspect may be altered by what foods we eat. I'm guessing here,
Hmm.
but I don't know for sure how to overcome bad dreams.
Sure. Thank you, Doctor. Even happier that you're a fellow HPS alumni.
Well, it's a small world, a very small world, Sirish.
Yeah. And I'm going to try this on my chronic migraine and, of course, buy the book immediately.
Thank
So,
you. Thank you.
yeah. So these are some of the comments I think people have thoroughly enjoyed. We've had a very interactive audience, as always. And I'm very happy that, we decided to do this and you accepted to come on this platform. So thank you so much for being here. And yeah, we had a good time. And this is the book, just so that everyone knows. I will put that up, The Pain Free Mindset. Yeah. And
You have a much better
like,
quality of lighting there.
yeah, and like I said, I mean, the word mindset is like, so easy to remember what each of these alphabets stand for. So thank you so much for your time, Doctor,
No,
and it
thank
was
you,
a pleasure
Soumya, for
having
having
you
me as
here.
part of the mindful running podcast there, and wish you the very best of luck. And yes, it's been really nice to reach out to you know my own deshvasi this way and lots of way, and I do want to come back and do a lot of this kind of work there. So thank you for this opportunity to
Yeah,
talk to all of you out there back in India,
yeah,
and stay safe, and I wish you a advance happy Diwali to all of you.
yeah. Same to you, and thank you for putting the mindset kira in our heads. Now we know what to do, and now we know what to ask our doctor next.
Brilliant, excellent, wonderful.
Thank you so much. Bye.
Cheers then.